Okay, we're going to be moving forward now with our next group of presenters. And this session is focused on the Arizona Alliance for Maternal Health Initiatives. We have 3 speakers, and it is a real honor for me to be able to introduce these 3 amazing individuals that are providing significant leadership and creating change within systems of care in Arizona. So our first speaker will be Vicki Bukta, who will present on optimizing maternal and infant care through Arizona AIM initiative. Vicki is a registered nurse, holds a nurse executive advanced certification, and currently serves as the vice president care improvement for the Arizona Hospital and Healthcare Association. Vicki leads collaboratively to improve patient safety, patient experience, healthcare outcomes, and health equity. She is a highly skilled professional with demonstrated expertise in clinical and systems leadership. Vicki served in nursing and leadership roles with health systems, including the Mayo Clinic, Hawaii Pacific Health, and Banner Health. After Vicki's presentation, we'll hear from Dr. Catherine Glaser, and she will present on experience implementing AIM bundles. Dr. Glaser is the obstetric gynecologist who has worked on the Navajo Nation for 11 years. Dr. Glaser completed her medical school and residency training at the University of Arizona and training in clinical research at the University of California, Davis. Her clinical and research interests include improving care related to hypertension and diabetes in pregnancy. Our third presenter will be Dr. Sarah Kalia, who will present on building capacity of frontline providers to promote maternal health in Arizona. Dr. Kalia is an associate professor of psychiatry at the University of Arizona and director of the Arizona Perinatal Psychiatry Access Line. Dr. Kalia's residency was completed at the University of Arizona in Tucson in 2016, during which time she earned the American Psychiatric Association Resident Recognition Award. Her contributions to the field of perinatal psychiatry include launching the Psychiatry Department's Perinatal Psychiatry Training Track and Clinical Service, and is working to expand the department services in this area. Additionally, Dr. Kalia provides national trainings for the Perinatal Psychiatry International PSI organization and has made significant contributions to the national curriculum of reproductive psychiatry and the American Psychiatric Association first textbook of women's reproductive mental health. She is a well-regarded educator, having won multiple teaching awards, including the Arizona Psychiatric Society's Howard E. Wuslin Excellence in Education Award in 2020. This is going to be a really dynamic group that is going to be presenting to us. And so at this time, I'd like to welcome Vicki up to the platform. Vicki?
Yes, thank you, everybody. I want to make sure I'm sharing my screen, and you'll see me looking off to the right just a little bit because I do have a double monitor and I want to be able to address my slides. But let me say, first of all, what an honor and a privilege it is to be here, and especially to follow Dr. Borders. We've been following her work in Illinois for many years, and it is truly inspiring. And I think one of her summary slides said it all, and that is, if we all just take a little piece, but if we work together, we can accomplish great things. And clearly Illinois has set the pace for lots of really great work. And in fact, Dr. Borders joined us for our AIM kickoff and was our keynote presenter for that. So it's truly a pleasure to follow her today and to tell you a little bit about our initiatives here in the state of Arizona. I have nothing to disclose, and I do want to really emphasize that this work is truly a partnership between the Department of Health as well as us at the Arizona Hospital and Healthcare Association. As you noted in the introduction, what we specialize in at OSHA is the ability to pull together people, especially hospitals, and get the work done through collaboratives. And so that's the contribution that we've made in this partnership. So a little bit about AIM. We've heard it mentioned a couple of times. Joy Burkhart mentioned AIM yesterday in terms of the maternal mental health or behavioral health bundles. We heard Dr. Borders talk a little bit about it today. So let me just back up and give you a couple of definitions so that we are all clear on what we're talking about. So AIM stands for the Alliance for Innovation on Maternal Health, and it is a national data-driven maternal safety and quality improvement initiative. That's quite a mouthful, but really it says it all. So, you know, we talk about evidence-based care, and it always makes me sort of wonder when I hear people talk about the fact that during a busy work schedule, we should go and look things up at the library and try to figure out what's evidence-based when we're taking care of our patients. We don't have time to do that. So we do trust our organizations such as the American College of OBGYNs to do that work for us and give us these safety bundles that really are proven to increase safety and quality. The bundles work to reduce preventable maternal mortality and severe morbidity across the United States. It's been shown over and over again. And I do want to acknowledge that this work is funded by HHS and HRSA, as well as the CDC, and we are also in the cooperative agreement with ACOG. So patient safety bundles are a structured way of improving processes of care and patient outcomes. Because what we know is that if we can reduce variations in care and increase standardization, we will have sustained improvement. Even if we're possibly not doing the right things, just by the fact that we're standardizing, we can improve care. The bundles are put together according to clinical condition specific elements and follow an evidence-based structure, as I mentioned. And they are proven to improve patient outcomes when they're performed collectively and reliably. So the whole idea behind this is to implement the bundles across all of the hospitals in our state and indeed across the nation. They're also very adaptable to a variety of facilities and resource levels. We always start with looking at data, those of us who are working in quality improvement, because what we know is that what gets measured gets managed. And there's different kinds of there's different kinds of data that we can look at. We can look at structure, process and outcome. Structure would be the policies and procedures, protocols, those elements that we have in place to allow this work to work. Process is the actual performance or completion of specific elements of the bundles. And then outcomes include those changes in health status, such as a reduction in severe maternal morbidity and maternal mortality. The AIM bundles include 5 major components, and they start with readiness, which is making sure that we're ready to go. A lot of times we think of the structure kinds of elements in that: policies, procedures, protocols. Recognition, or do we know what it is we're looking for? Have we done education for the staff? Response, which is treatment, and in this case we'll be talking a lot about that, and then reporting and systems learning. And a key element of all of this is the 5th one, which is respectful care. And as Dr. Borders talked about, it is absolutely essential that we integrate respectful care into everything we do. And by the way, I love the idea of a respectful care breakfast. I think that is just amazing. But so many times what we've done in the past is we have said, well, we're just going to take care of the patient and then we'll worry about all that equity stuff later. And what we know is that equity is not the icing on the cake. And how we really need to think about this is reframing our approach so that we actually embed equity. And we like to think of it as the funfetti approach, where we've got it baked into absolutely everything we do. And again, Dr. Borders gave us some amazing examples of that. So we took a look at data and we started looking at the severe maternal hypertension, not only in our own state, but in the country. And what we saw is that hypertension and preeclampsia accounts for about 9 to 10% of maternal deaths in the United States, a full 1/3 of severe OB complications. It affects preterm births, with about 6% of preterm births being related to this, and then also can affect the neonate or infant. So it definitely contributes to NICU admissions, stillbirths, and neonatal deaths. In our own state, we saw that in 2019, well, between 2016 and 2019, we had a dramatic increase in the number of cases of severe hypertension. And actually the increase was higher than the rate of live births in the state of Arizona. We also parsed the data and looked at chronic hypertension versus hypertensive disorder of pregnancy, because there was some thought that, well, if people are chronically hypertensive, maybe that doesn't really affect the how it is that they are how it is their care is and the outcomes are for these patients. But indeed, that did not hold true. Chronic hypertension, as well as hypertensive disorders of pregnancy, definitely contribute to severe mortality and severe mortality and severe morbidity. And in 2019, just to kind of put a number to this, there were over 2,500 hospital births in Arizona with severe hypertension. So the Arizona AIM Collaborative started in 2020 when ADHS and ASHA partnered, and we set up a steering committee. Now think back to 2020, we were deep into COVID during this time. We started the steering committee in June of 2020. We brought together about 30 individuals from throughout the state representing different disciplines to start this work. And we selected some goals to reduce maternal morbidity and mortality through the implementation of the safety bundles, and really made that commitment to using data to drive improvement. And based on all of the data, we decided to start with hypertension. And actually, I'll tell you, hypertension and hemorrhage were sort of neck and neck, but we were encouraged by the CDC to start with hypertension. So our AIM statement that we selected at that time was to reduce the rate of severe maternal morbidity and mortality in women with severe preeclampsia, eclampsia, or preeclampsia superimposed on pre-existing hypertension by 20% in participating hospitals by March of 2023. And actually, we mimicked what Illinois had done. They had selected a target of 20% reduction, and we thought that sounded reasonable for our foray into this work. We knew that we couldn't tackle absolutely everything and measure absolutely everything, but we needed to focus on a couple of key elements. And we made the decision to focus on reducing time to treatment and debriefs. In terms of time to treatment, what we know is that it is very important for people who have 2 consecutive blood pressures of greater than 160 systolic or 110 diastolic to be treated within 60 minutes. And indeed, some hospitals have even set goals of 30 minutes. But AIM has set forth 160 over 110 and 60 minutes, so that's what we went with. And we said we want to set this goal at 80%. And then we know that if there are misses, so in other words, we did not treat that person within that 60-minute time frame, that we should circle back as a team and talk about what happened. Did we miss it by a minute? Did we miss it by a mile? And was it a miscommunication, or how could we improve care the next time around? And we said, let's make sure that at least 50% of the time we are debriefing those cases where we did not meet that treatment goal of treating the person within 60 minutes. Here was our baseline data. We asked our hospitals to submit a full quarter's worth of data, which turned out to be April, May, and June of 2021. And as you can see, for that particular quarter, the current measure for reducing time to treatment in terms of the getting the treatment within 1 hour, we were at about 56% of the time. The goal again was 80%. And then for those times that we missed, we had a lot of hospitals saying they were doing debriefs, but when we actually measured it, we saw that we were actually debriefing about 7% of the time. And again, our goal was 50%. So we knew we had opportunities to work on this. So we did a kickoff with hospitals in April of 2021. As I mentioned, Dr. Borders was our keynote speaker. We reviewed data collection methods, the AIM bundle elements, the toolkits that were available, and change packages. After that time, we hosted monthly coaching calls, and we've had attendance. We range between 40 and 60. I'd say that's probably an average, and the range. We've had some that are over 100 people on a call. And some of the more successful ones have been where we've had hospitals present challenges and successes to each other. We work through challenges with those plan, do, study, act cycles. We bring in subject matter experts to present, and we have done quite a few trainings on health equity. We also offer one-to-one technical assistance to each participating hospital. We send quarterly data infographics to hospital C-suites and maternal health leaders for review. And this was actually at the suggestion of one of our steering committee members who said, you know, it's really important that not only our OB leaders know what's going on in hospitals, but that the C-suites know about this great work and that they see the data so they can see their own hospital's progress. And we'll share with you that we have seen that has been highly effective in helping to really spark these initiatives. We do maintain data dashboards for the hospitals to maintain their progress real time so they can monitor their own progress. And then we had our first annual maternal health conference last year where we provided wonderful education. We had great speakers and a lot of exhibitors, which our participants really appreciated, along with networking opportunities. I want to circle back and talk a little bit more about the hospital sharing and learning, because what we've heard from our hospitals is that this is one of the really key things. Learning from each other is so very important. When it came to debriefs, we learned from some hospitals that they were starting from scratch on this, and others were established, but when they collected data, they found inconsistencies. So we had them talk with each other and share best practices about how they're accomplishing the debriefs. And overall, we've found this to be extremely helpful. We know that hospitals are still sharing protocols and policies and continuing to refine those. And we've also had quite a bit of sharing about enhancements with those electronic medical records to build in triggers and notifications for early warnings and alerts. And that's been really helpful. We also have spent quite a bit of time on when to treat and myth busting. We hear a lot about, worries that if we treat the patient, then their blood pressure might drop too much when we start their epidural, or that if they're in the middle of pushing, it might not be an accurate blood pressure. But we've really worked hard on trying to make sure that everybody is understanding that when we have those 2 consecutive blood pressures, we must treat. And then some of the health equity myth busters we had we really have worked on talking through are things like, we treat everyone the same. And ideally we would, and in terms of the bundles, that's exactly what we want. We do want everyone treated the same. But outside of the bundles, really, we need to individualize patient care when it comes to health equity. So we've spent time talking about that. This is an example of the Arizona roll-up dashboard that we have been creating on a quarterly basis. This one is a roll-up, includes all data starting from June 2021 and goes through June 2023. This landed on in my inbox yesterday afternoon, and so I quickly updated these slides so that you could see our latest data, including that the latest performance period through June of 2023. You can see that we're not quite at 80% yet in terms of hypertensive patients treated within that first hour, although we have seen improvements quarter over quarter. And we're not quite at the 50% rate yet for 32% of patients debriefed. But I will say that since we're doing better with treating patients with 1 hour, we have fewer misses where we didn't treat. So seeing that debrief number come up has really made a huge difference, and the numbers are much smaller of the patients not being debriefed. At the bottom part of the graph here, you can see, and if you might not be able to read the numbers, but the colors can tell the story, because red means it's clearly a miss with less than 70%. Yellow is at 70%, and you can see this is treated within 1 hour. Our baseline was 55%. We were in the red, then the yellow, then the red again, and now we're back up again to 72% for the last quarter reported. Debriefs, you can see we are not quite at that 50% yet, but we have gotten better. And then not treated, not debriefed is a number that we continue to work on because we believe those are the cases that we can really learn from. We also have quite a few large health systems in our state participating. And so we created a dashboard specifically for them so that they can talk with their C-suites about how they're doing as a system. So this is a sample system dashboard. It is a roll up through March of 2023. And really the take home here is that this system is at 70% of patients treated within that 1 hour from April of 2021 through March of 2023. They still had a ways to go on the debriefs, but you can see, and I think this really tells a nice story of the treated within 1 hour. Look how they were in the red and then went to yellow and then went into the green. And for that last quarter that we have reported, for this particular graph, they were at 94%. So that is just huge. Not treated but debriefed were 2 patients out of 4, and then treated but not treated, not debriefed were 2 patients out of 4. So they only had 4 patients not treated within that time frame as a system, which I think just tells a fantastic story. And we also then, as a benchmark, we have here the Arizona average for those that were treated. And I will share with you just anecdotally that when we started the AIM project, this system said, hey, we got this. We've got policies and procedures. We've been doing this. We'll serve as a mentor to others in our state. And we said, that's just fabulous. We're so happy to have you. And when they started collecting data and looking at it, they realized quickly that they had some work to do. So really a great story of taking a look at data, using that data, and then making those improvements. Oops. Next steps, we have site visits planned to our AIM hospitals. We're considering a listserv. We have lots and lots of materials online, and including examples from our various hospitals for peer-to-peer learning. We're continuing to work on implementation and quality improvement. We do let the hospitals choose what they want to work on based on their data and support them with their 30, 60, and 90-day plans and those PDSA cycles. We do have our 2nd annual conference planned for this September. Here are some photographs from our previous conference. It was really a lot of fun. As you can see, we had a lot of engagement. We had over 150 people attending. All of the presentations are on our website, and as well as photos from that conference. So I encourage you, if you weren't able to attend or would like to view any of those recordings, you certainly can do so on our website. Just a bit about our hospital participants. We have 34 out of 41 hospitals participating. We did have 1 hospital close at the end of June, so that number was 35. We've adjusted everything now to 34, but that does represent over 90% of the births in our state. So that's really great. And we do have 2 IHS facilities participating, with about an average of 28 to 32 facilities submitting their data every single month. That is really fantastic. And I was informed when I got the data yesterday for that last quarter that we had almost 100% of data being submitted. So that's just fantastic. We do continue to recruit. And in the next slide, I'll show you all the hospitals that are participating. If you don't see your hospital, please reach out to us. We'd love to have you join us. And we're also happy to welcome birthing facilities who would like to join. I have talked to some of the leaders from those facilities, and they have indicated that they like to transport quickly if they see any issues arising, but clearly we would love to involve them in whatever way we can. So here are the hospitals that are participating currently. They're in alphabetical order, so I'll give you a moment here to just have a quick peek and see if your hospital is participating. As a next step, we will continue to work on improving the care of people with hypertension. We know that we're not yet at that 80% point, and we're not going to take our eye off that ball, but we are going to implement the next bundle. So we're going to be kicking off the hemorrhage bundle at our September conference, which is coming right up. And we're working actively, not just with the hospitals, but also with health plans and others who can support this work. So, for example, making it easy for health plan members, whether they're access or otherwise, to obtain blood pressure cuffs. and working with health plans to provide incentives for hospitals and providers to hit these metrics. So with that, I want to thank you for your time today. I'm happy to take questions, I think, at the end of all of the panelists.
Yes. Thank you so much, Vicki. Good to see you. I really appreciate you sharing all of the amazing work that's going on in Arizona. Thank you for your leadership. And now I'd like to bring up Dr. Glaser to the platform for her to present her presentation.
Thank you so much for your introduction, Patricia. As you said, I'm an obstetrician gynecologist. I've been working in Tuba City for 11 years now. I'm very excited to be here, but more so, I'm really excited to see that there are over 300, almost 400 people here who are concerned about the state of care for birthing people in Arizona. And I am also happy to see so many familiar names, if not faces. I have no relevant financial disclosures or conflicts of interest, but perhaps obviously I'm employed by the hospital at Tuba City Regional Healthcare Corporation. The learning objectives for this talk are to review some factors contributing to maternal mortality in Arizona, but since we talked about that so much yesterday and Aubrey did an excellent job, I will very briefly review that. Vicki has given you a wonderful overview of the goals of the AIM bundles, so I don't have to do much work there either. But I will tell you a lot about our experience in Tuba City implementing AIM bundles in a rural Indigenous community. And of course, that's just one facility in Arizona in our experience, but hopefully people can take something from that and as they work in their own communities, and we can learn from each other. Also, there's always challenges, as Dr. Borders said, with any quality improvement initiative. So I'll talk a little bit about that too. So this next slide is obviously extremely busy, and I have no desire to tell you about everything that's on it, but I just want to take a moment to recognize that maternal morbidity and mortality is extremely complicated, and that was mentioned a few times yesterday. There are a lot of factors that go into it. If you can see my pointer there, I'm just going to talk about protocols and safety bundles, which is one item in the third column. But there are all the things that any pregnant person brings to their pregnancy from outside, from their family, from their community, and then also the community factors as well and system factors. So as we work to change maternal mortality and morbidity, I just wanted to take a moment to recognize that there's a lot of factors in it. Aubrey, as I said, did a beautiful job of reviewing the most up-to-date information from the Arizona Maternal Mortality Review Committee yesterday. And in her data, so my data is from the data that was available when I put these slides together, but her data yesterday recognized that 5.8% of births are to Indigenous people in the state of Arizona. And unfortunately, in her data, that percent of deaths had increased a little bit. It was 14.8%, but still Indigenous people in the state have the highest mortality rate. The numbers are small, of course, overall, but each of those deaths represents the loss of a person to the family and community, so is enormously important. Indigenous people in Arizona are also at risk for the highest serious maternal morbidity. I wanted to take a moment to recognize that again. So to switch gears, I'm going to talk specifically about Tuba City Regional Healthcare Corporation. This is a picture of our hospital. The three-story building in the foreground of the picture is where we provide our outpatient primary care, which is labeled on the building there. Our clinic, where we provide care for pregnant people, is located on the third floor. And then that low slung building in the background is our main hospital facility. So there is where our labor and delivery is, our inpatient units, our pediatric unit, radiology and lab, and pretty much all the other services for the hospital. If you haven't been to Tuba City, I could mention that the three-story building that is our outpatient clinic is one of two multi-story buildings in the community. So definitely more rural than some of you in other parts of Arizona. Tuba City Regional Healthcare Corporation is licensed as a 73-bed hospital, and it's located on the western part of the Navajo Nation. Due to nursing constraints, we don't operate that many beds, but that's what we're licensed for. And the mission of the hospital is to care for pregnant people and women of the Navajo, Hopi, and San Juan Southern Paiute tribes and tribal communities. In our most recent years, we usually have between 350 and 400 births per year. So much less than some facilities, but that's what we're doing at this time. We talked yesterday a bit about maternity care deserts, and Coconino County, which is where the hospital is, definitely doesn't qualify as that based on the numbers, but it is probably worth recognizing that Tuba City is about 75 miles south of Page, north of Flagstaff, and then to reach a hospital to either the east or west, it would be quite a long distance. So we have facilities, but everything is a bit spread out, which is probably true in most of rural Arizona. This picture, I just wanted to take a moment to share. It's a photograph from the New York Times from an article now that is 13 years old, but that talked about our trial of labor after cesarean delivery program. It's a beautiful article, and this picture is very beautiful. This is a family who had recently had a child and their ceremony to celebrate that child. Yesterday, we talked a lot about the role of midwives in providing care in the state, and I can share with you that our care model is a team of certified nurse midwives and obstetrician gynecologists, and we always work together to provide our care. Some of the elements of our prenatal care include the fact that we are a baby-friendly hospital, which really means that we have an emphasis toward breastfeeding as much as possible. Importantly, about 20 to 30% of the pregnant people at any given time receiving care have gestational diabetes or overt pre-existing diabetes. So that is one of the things we care for and makes the pregnancy care a bit more challenging. We have a program related to that with a dedicated registered dietitian that helps provide counseling to help with that care. About 80% of pregnant people at any given time are overweight or obese. So that is another complication that we often care for. And as I mentioned, when I shared the pictures of Tuba City, all our services are located at the same site. So that is a convenience that no one has to, once they've gotten there, they don't need to travel any further. Our inpatient care model is a labor and delivery unit that's staffed always by a nurse midwife, a certified nurse midwife, and they're all women now. So she's always there either in a 12 or 24-hour shift. And there's always an obstetrician gynecologist available almost immediately for concerns or if a higher level of care is needed. I think that is a great model of care for us. It means that we have the what was described yesterday as the holistic care provided by a midwife with the safety of the higher level of care that can be provided by an obstetrician gynecologist. And it also, I think, helps with what I'm very proud of, which is our C-section rate. Again, when you have small numbers, a percentage can vary from year to year, but some years it's been as low recently as 14%. And I don't think in any recent memory, it's been higher than 18%. So I think that's something that's really good for the people we're caring for. So as we started the AIM implementation, which Vicki describes so well, we were one of the hospitals that was involved in the April 2021 kickoff. Things that we were already doing and continue to do were drills, which happen either every month or every other month and tend to focus on common things like hemorrhage, hypertension, malpresentation of a fetus, and other topics that are pertinent. We are certified by the Arizona Perinatal Collaborative, Arizona Perinatal Trust, which is our quality collaborative in the state. Sorry to tangle those words up, and have been for many, many years. This is, of course, a voluntary certification program, but something that we're quite proud of. And in fact, we had our site visit just 2 weeks ago and received recertification for 3 years. So we're very happy about that. We've always had case reviews of any cases which would be outside of what would be expected, and that provides learning for all of us. And we were late to come to electronic health records, but implemented those in 2017 and have order sets within the EHR that allow us to quickly ensure that we're ordering the right things around hypertensive medications. Additional things we started to do after implementing the hypertension bundle were a required training about hypertension. And we used a platform that we had in place at that time. And we're now transitioning to a different electronic platform just to review the criteria for severe hypertension and the treatment. We also began to measure whether or not our treatment occurred within an hour of the diagnosis of severe hypertension, and to include debriefings. So those were all new elements for us. This is what was available when I put the slide together as far as our most recent number of people needing to be treated and fallouts. You can see that in the most recent months, we've had between 0 and 2 people needing treatment, and we did have a significant fallout in November when there was 1 person who needed treatment and did not receive that treatment. What happened in the November case was that there were 2 elevated blood pressures noted while the patient was receiving an epidural for pain during labor and delivery, and they were not treated at that time. An additional severe range pressure was noted approximately 3 hours later, and at that time, the treatment was administered. So it was definitely much later than the 1 hour time window. The debriefing did occur, and it simply felt to be due to the busyness around the time of receiving the epidural, but definitely not ideal. To my recollection, we've had 1 other fallout, which happened quite some time ago and seemed to be related to a transition from one type of medication storage unit to a different one. It was just a delay in removing the medication from that storage. I think that one of the things that's really helped us to be successful is that we are all employed. So we set guidelines for our group, and we decide to sort of dance to the same tune. And there isn't really the situation where somebody can say, well, I don't want to do that, or, I'd rather wait and see what happens with the blood pressure. We have uniformity in our guidelines. So I think I have a few minutes left, so I will just briefly talk about what we've seen as our next steps. One thing we wanted to do is have that respectful care, of course, in every encounter that we have, but to help with that, we wanted to offer additional training in post-birth warning signs and implicit bias. So one thing I'm happy that we've been able to do is receive grant funding to allow us to offer the March of Dimes implicit bias training. And that's training the memorandum for the grant funding is being signed this week. So that's funding that will allow us to be able to implement that training for the nurses, physicians, certified nurse midwives, and support staff, both on labor and delivery, but also really importantly in the emergency department, because we know, even though we've tried to make labor and delivery the place for all care before and right after delivery, sometimes people go to the emergency department, and our colleagues there are wonderful, but we want to make sure that they've also received the same training. So I'm really excited to be able to do that. When we thought about next bundles to work on as far as AIM bundles, we were thinking to do the hemorrhage bundle, but as Vicki really well explained, the launch of that will be next month, and we plan to do that after that. For good or bad, we have a lot of real world experience with hemorrhage as a complication that we see a lot. So I'm interested to see if we're doing all the right things. I like to think we are, but the bundle will give us a chance to measure our practice with the best practice and make sure we're doing that. So in the interim, we started working on the substance use bundle. And I would say that bundle is definitely stretching a bit further than any bundle that's just on labor and delivery. With hemorrhage and hypertension, those are more local problems, but substance use stretches through those of us who work on labor and delivery, and also our partners in psychiatry, case management, and pediatricians. So briefly, just to say that the challenges there are making sure that we're using the best screening modalities, which I'm working on, and also making sure that we're all, again, dancing to the same tune as far as how patients should be screened, and making sure that our practice now is the most up-to-date with current I would say the best treatment for people experiencing substance use, because we, as everyone has recognized, definitely don't want to push people out of care by being perceived as being punitive in any way. The other small part of that is making sure we're in compliance with Arizona statute. So challenges, I guess, as I've said, are some pre-existing ideas around care in substance use, and also competing interests. As Vicki recognized, implementing something while other things are going on can be a little bit hard. And as a clinician who also gets to wear the cap of an administrator, sometimes issues come up that push bigger projects to the background. And I wish that didn't happen, but that is also a challenge. So I will wrap up there, but obviously I'll be here for questions at the end. Thank you so much for your time and attention.
Thank you so much, Dr. Gracer. That was a wonderful presentation. Okay, now we'd like to bring up Dr. Kalia to the platform.
Hi, everyone. My name is Sarah Kalia. I'm the director for the Arizona Perinatal Psychiatry Access Line. And I just want to take a minute to say thank you guys for having me. And the last day and a half has been both sobering and inspiring, which is a very hard tone to hit, but somehow it's been managed here today. And as I'm going to talk a little bit about sort of maternal mortality with a focus on maternal mental health. And one of the pieces that we're doing, and hopefully kind of adding to the various solutions that we do need here today. So I have no financial disclosures, and I know that we've talked a lot about maternal mortality, and so I don't know that everybody needs this reminder, so I'm going to keep it quick. I just took off a couple of slides as we were talking earlier today. The maternal mortality in the US far outstrips that of other industrialized nations when it comes to maternal health. The problem when it comes to maternal mental health is a big one. So it is the most common complication of pregnancy. It's about 1 in 7 people when you're looking at perinatal mood and anxiety disorders. And when you expand that to include substance use disorders or things like ADHD, that becomes 1 in 5. By comparison, preeclampsia, which of course pregnant people are screened for frequently, is 1 in 25. And these are treatable and preventable causes of maternal morbidity and mortality. And I want to talk to you a bit about the mortality piece, especially in the state of Arizona. This is the AZDHS data. And when you look at the data sets, this is 2016 to 2018 data. This is directly a snapshot from them. Almost half of all pregnancy-associated deaths in Arizona were related to mental health conditions or substance use disorders. While that is sobering in itself, I want to draw attention to this number, which is 98% of pregnancy-associated deaths related to those mental health conditions or substance use disorders were determined to be preventable, which is a pretty horrific thought when you think about it, because these birthing persons, these moms, were taken from their families, their communities, and it's a pretty hard thing to think about that when it's an idea that it was preventable. The problem becomes mental health conditions are really tough to target and deal with. And then let me talk a little bit about the substance use piece, because a lot of people have talked about that piece. And then when you're looking at deaths in Arizona related to mental health conditions or substance use disorders, the number one substance involved was opiates. So we're still needing to kind of work with that with opiate treatments as well. The other thing I'll draw your attention to is that it says marijuana was 27.4%. And I'm going to say, the reason why it's low in terms of that number is because this is probably death data and it's not use data. Use data, I'm pretty certain in our state, is pretty high. The disparities when it comes to maternal mental health, Black and Latina women are about 33% more likely to experience perinatal mental illness compared to white women, and African-American pregnant women are in need of such more work as well, because when you look at the data, we'll also find that they are more likely to develop postpartum depression due to chronic environmental stressors, et cetera. And so women of color are considered not only more likely to develop perinatal mental illness, but specifically depressions. In the state of Arizona, this is this is MMRC data, by the way. I don't know if I mentioned that earlier. And so when you look at who in Arizona and what our distribution is in terms of who's giving birth on this side and who's experiencing maternal mental health conditions on this side, there's clearly a disparity when it comes to American Indian and Alaskan Native population. They're not, they have significantly higher burden of mental health conditions or substance use disorders in comparison to the amount of births that they're having, and also notably for white patients as well. When you think about perinatal mood and anxiety disorders, there's a significant cost. And I'll talk about cost in terms of just the actual dollar cost, and of course, cost in terms of the intangibles as well. And in from 2017 data, when you look at it, untreated perinatal mood and anxiety disorders have multi-generational cost consequences, and they're about 14.2 billion for all births. This is cost of medical care, inappropriate medical care, child abuse, neglect, discontinuation of breastfeeding, family dysfunction. This is kind of all of that cost in itself. When you look at dyads, so they broke down in terms of the cost of depression. So this is cost of untreated depression for mother-baby dyad. It's about $32,000 a year. When you apply that to about 20% of births in Arizona, and that's a lower ball because I just wanted to give you the more consolidated numbers, that averages to about $375 million in cost to the state of Arizona. That is taking into account, we're assuming 20% get treated. That's not always the case. If nobody's treated, that cost is about $477 million. This is a pretty high cost in terms of just the dollar amount. And I'll tie back to that in a little bit when we talk about some of the options and various solutions and one of the levers that we're pulling. The other piece in terms of cost is the cost to the mother, which is of course increased risk of miscarriage, antepartum and postpartum hemorrhage, gestational hypertension, suicide, preeclampsia, poor attachment. So there's a lot of health costs both to the mom in terms of the direct cost to the mom, as well as sequelae of cost to the pregnancy in itself. Babies with moms with perinatal mood and anxiety disorders or other substance use and mental health issues are at increased risk of preterm birth, NICU admissions, low birth weight, neonatal hypoglycemia, microcephaly, increased risk of psychiatric illness in their childhood, motor delays, additional problems. And of course, there's a cost to the community in terms of average cost of the mother-child dyad, which I mentioned. The other piece that I haven't mentioned here, which I think is really important to talk about, is the risk of paternal or spousal depression. I can't say partner because the data set I'm quoting is paternal, and that's just a heteronormative data set that we have at our hand, and we can postulate that it applies. But when you look at the risk of depression to the father or the partner, it's about 1 in 10. So 1 in 5 women would likely have some sort of mental illness or substance use disorder, and 1 in 10 partners or spouses would have something else as well, which is a pretty serious thing when you think about sort of the family effect for untreated perinatal mood and anxiety disorders, and of course, how common they are. Because the idea is, as we all know, healthy families will lay the foundation for a productive society. The other piece when it comes to the perinatal mood and anxiety disorders is we know they're prevalent, but they're still underdiagnosed and untreated sometimes. 75% of people who do screen positive for mood depression do not receive treatment. And this can, of course, lead to devastating effects as well. For depression alone nationally, people are just 60% are never diagnosed, and then they don't get treatment. For specifically mood and anxiety disorders, the number gets higher. Challenges of that is it's hard for providers to say, I'm going to go screen them because I don't know what to do afterwards. And part of that is mental health care shortage. Mental health care professional shortage areas, healthcare professional shortage designations are used to identify areas and population groups within the US that are experiencing a shortage of health professionals. And so there's multiple categories, which is primary, dental, and mental health as its own category. And so for mental health, the population to provider ratio must be at least 30,000 to 1. And as you can see in Arizona, we're definitely in the lightest color. We have one of the harder shortages in the state. I'll give you some state data just so you have a sense of what that looks like. So this map is showing you the behavioral health workforce for 2020. So this is looking at behavioral analysts, counselors, marriage family counselors, psychiatrists, and psychologists. So it's not all all kinds of behavioral health providers. Basically, this is Center of Rural Health data, and they were looking at those with licensing boards that they could pull data sets from. And what I want to point out is, even though we have a low amount of mental health providers in the state, as the last map showed you, we have a huge disparity in the state in terms of where the coverage is and where providers are. So Maricopa is obviously unexpectedly a significant high number of providers, but then you look at the rest of the state and we're not the same scenario. In terms of looking at the behavioral first workforce by rurality, the blue bar shows the urban concentration versus the tinier bars are the rural concentration. So we also have a problem within the state in terms of how that workforce is spread around. And telehealth, of course, has helped in that, but it's not the same. And behavioral health workforce is a larger term. When you look at psychiatrists, because we'd like to have every patient who has mental health conditions seen by a psychiatrist, unfortunately, that's just not a realistic target. And I'll tell you why. The total number of psychiatrists in Arizona in 2023 is 915, which is a very, very high, very, very low ratio in terms of like providers to patients to providers, and then huge variation in capacity across the board in terms of where the psychiatrists are. I'll show you a map in a second. But even within those 915 psychiatrists, I couldn't tell you how many of them take access or how many of them take insurance, and let alone who are trained in reproductive psychiatry and kind of managing that particular subset of the population, because it is a subpopulation that does need a little bit of extra considerations and care. So when you look at that map, taking into account just the psychiatrists, again, that psychiatrist population is Maricopa, Pima County, but when you look at the rest of the state, La Paz has no psychiatrists, and you can see single-digit numbers across the rest of the state. So we also need to think about not just the fact that we have a low workforce, but also that workforce is very urban focused. And again, we're not the only ones. So this is the map for the workforce for OB providers, so certified midwife and OB physicians. Again, same scenario, La Paz has nobody. And then we have a higher concentration in Maricopa and Pima counties. So this becomes a big challenge when we're looking at high rates of disease, small amount of providers, and kind of distribution of providers isn't great as well. Maternal mental health is being recognized by many professional organizations and policymakers that are all recommending screening and imploring providers and practices to integrate mental health care into obstetric care. It would be great if they could all see psychiatric providers. That's just not going to happen. And so perinatal period, and part of the reason that I'm going to pitch to you sort of the solution, one of the solutions, one of the levers we're pulling is that time period is really ideal for detection and treatment. Most mental health conditions currently are treated by primary care. A woman will see a healthcare provider an average of 25 times during that 2-year time frame from conception to the baby's first birthday. So there are regular opportunities to screen and treat. It's hard to kind of call up and say, I'm going to go see a psychiatrist, but most psychiatrists' wait times in Arizona, at least in Tucson, are like 3 months out. That's a very big time frame in a pregnancy postpartum consideration. And so we do need a solution that will address perinatal mental illness, that will address sort of the issues of rurality versus urban distribution of providers, that will help our frontline providers in terms of providing care for this population in a comfortable way that do want to care for them, but sometimes are like, I don't know what to do with this patient. And so what we decided to think about was perinatal psychiatry access programs. So I'll tell you a little bit about what they are and then kind of go into what we're doing. The perinatal psychiatry access programs are designed to address gaps in that care, right? Increasing the capacity of frontline providers to screen, treat, and sometimes provide resources. There's about 20, at least to my knowledge, across the state. That does seem to change because some of them are HRSA funded, et cetera. So they are popping up across different states. Across the US, we have about 20 right now. And most of them will have one of these 3 arms, right? Education, consultation, resource, and referrals. So for example, the PAL line in Washington, which is a perinatal access line for Washington, they do education and consultation. They do not do resource and referrals. The McPAP line, which is the first original line in 2014, that started out as a child psychiatry access line and had like a teeny bit of money left, and they started the perinatal psychiatry access line. They do all 3. Wisconsin has the Periscope project. They also do education and consultation. They do not do resource and referrals because resource and referrals is a challenging task to take on. When you look at data, it's because it hasn't been around for too long. So MCPAP was the first line and launched in 2014. We're going to hit 10 years of these perinatal access lines next year. So we haven't been doing this a long time, but I will tell you a little bit about what we know. So the first paper kind of talks about the development, implementation, and outcomes of the MCPAP program. And when you look at the volume of encounters, number of women they ended up serving, they found that MCPAP for Mom was a very feasible, acceptable solution, and it ended up costing about $8.38 per woman per year, which is about 70 cents per birthing person, per perinatal woman per year. When you look at, and it's good, and that's cheap, but what good is cheap if it doesn't work? And so then they went into looking at, does it actually work? And so they used focus group data, survey data to see what actually the outcome was. And they found that utilization for MCPAP for moms facilitated clinicians' ability to provide mental health treatment to patients, which is kind of what we're after, is ability to kind of facilitate the front lines, ability to provide that care. And so with that in mind, we're looking at what their outcome data is. We decided to go after this ourselves. So now Arizona is on the map, and we have the Arizona Perinatal Psychiatry Access Line. This is kind of the rest of the states that we have. So we implemented the Arizona Perinatal Psychiatry Access Line, and we do 2 of the 3 arms that most places do, which is the direct clinical consultation, education, and training. We don't do direct resource and referral in terms of like you call us and you're like, my patient needs to get into an IOP. Unfortunately, we can't do that for you, but we are running, we're keeping an up-to-date list of resources on our website. So for patients and families. So that resource list is getting updated and pulled together. But as you all know, it's kind of a desert in Arizona, depending on where you are and what services are available. So we can't always provide that resource and referral. Would be great if we could. So in terms of trainings, these are free. And anybody can kind of request it for your clinic, your hospital system. We'll do Zoom trainings, we'll do trainings in any way. This is just a small list of trainings on our website. If there are things that you're finding, I would like to get training on cannabis and pregnancy. I'm just saying that because that's one that I'm writing right now. We'll do that, and we'll come and do it for free. We're in the process of figuring out how to get CME CE credits for that, just to make it more tempting for people. Because again, the goal is, this is a free service. It's as equitable as you can make it. You can call on any patient. It doesn't really make a difference in terms of what their race is, what their insurance status is. Doesn't matter. Call us and we'll do that consultation, and also we'll come and help you train your staff and your team as well. So the one thing I want to make sure that I clarify, separate out, is it's not telepsychiatry. It's not direct care. So I'm not seeing the patient. We are hoping to get to that point, just because I miss patient care, but we're consulting with the provider. So it's the quality of the consult is based on the information you give us. So provider calls, we get a little bit of data set, because we do have to return some of that, like what we're finding in the state, back to people, and hopefully to you guys at some point next year. And then we consult on the case. And once we're done consulting on the case, we will send like a write-up of that consultation back to the provider. Because I find that providers are so busy. They're like, just tell me what to do. I have this patient in my office. And the couple of calls we've gotten are saying, I wish we could talk longer. Can I call you back at a different time? So we're working on getting that scheduling, as well as like, you can call us on your admin day and we'll schedule that time for you. I have mentioned obstetric providers, but honestly, we're taking calls from all of the frontline. So far, it's been like 50% OB providers, 40% psychiatric providers, and like the rest is like family medicine. And a lot of trainees have been calling. And the other thing that I will say is, for a service that is serving the entire state, we're a very lean setup. So we've got like 1.3 clinical FTE. And in that 1.3 FTE, if we were providing direct clinical care, we would not have the scope or impact that we are having right now. And again, as I mentioned on our website, we have a bunch of resources available. I'm getting the signal that I'm getting overtime. So I will stop with just one last thing. Engagement is huge for us. It's not a scenario, if you build it, they will come. So I really need today, for if you're thinking about it, please tell people about us. I want that phone ringing off the hook. So if you can, please tell us about it. If you have any guidance or etc., I'm happy to hear it, and please call us. You can reach us at team@apal.arizona.edu, and we know that we're one piece of the levers that we're pulling for maternal mental health, and we will happily collaborate with you to help in the others. So I'm going to stop here, because I think we were going to stop for questions.
questions. Yes, thank you so much, Dr. Kalia. We are a little over on time, but I do want to go ahead and ask at least one question to each of our presenters. And so, Dr. Kalia, since you're still on the screen, one question that came in from Kelly Leyland, she asks, are you all on the community cares list to refer to?
I actually don't know the answer to that, but how do I get on the community cares list if I'm not?
Kelly, if you can put that response in the chat, that would be wonderful, and we can be sure to share that with Dr. Kalia. Dr. Glaser, this question is for you. Do you know if there are any statistics on how much the implicit bias training improves patient outcomes or reduces disparities? That's from Ashley Schuss.
Unfortunately, I will have to echo Dr. Kalia and say that I do not know if that's been measured. I'm sure there's some data about it, but I'm not sure about it, but I'd be interested to see that as well.
Thank you so much. And this next question is for Vicki. Vicki, the question reads, it's from Isabel Fangman. I'm very interested to hear about how or if the standardized care can be given with respect to cultural traditions that we heard about yesterday. Is there ever conflict or tension? If so, how is that managed?
Boy, that's a great question. I think when it comes to treating the patient's blood pressure, we need to be really careful that we do that every single time. But as Dr. Borders pointed out, definitely the Hear Her campaign and involving patients in care, in their care, and providing that respectful care is so very, very important. I can't think of a current example of where there would be a conflict between what it is we're doing in the bundles for direct patient care and those care traditions. So if anybody is aware, I would like to kick it back to you to please let us know. And we could always take that back to AIM also to get guidance.
Okay, thank you so much. There are a few other questions that will, if it's okay with our chat team, if you'll put them back into the chat box, and then we'll let our guest speakers address, that would be wonderful. Thank you so much, Vicki.